Assalamu alaikum everyone. I hope you all are doing great. So let's share the screen with you guys. I hope my screen is visible to you guys and I'm audible to you. Do let me know in the chat section kindly. Am I audible to you guys? Hello. I hope I am audible to you guys. Okay, so without any delay, let's start with our lecture. So today our topic is Foundation of Dental Radiology, Principle. Sorry. Uh, so today's topic is basically Foundation of Dental Radiology, the Principle and Practice. It's first webinar of the Radiology webinar series. So let's open. This is introduction a little bit about me. My name is Dr. Farrukh and I am graduate of Marble Institute of Health Sciences of 20th batch in 2021. I had a distinction in oral medicine. I am founder and director of Experience Dentistry as well, and I am founder and director of PRIDE as well, Pakistan Research Institute of Dental Education. I am also a research supervisor of PRIDE and currently supervising around 25 plus researchers. And I am author of 5 research publications as well. I have 5 research publications, out of which 2 are internationally published in the journals. Okay, so this was a little bit introduction about me. Coming towards today's topic, so let's start with the name of Allah Subhanahu wa Ta'ala. So first thing, as when we discuss about the dental radiology, is basically its introduction. So dental radiology is basically a cornerstone of modern dentistry and playing an essential role in diagnosis, treatment planning, and long-term patient care. So dental radiology plays a very much integral part in our day-to-day life when you are going towards diagnosing a case, trying to make a treatment plan, and also for patient cases and for going for any kind of surgery. Okay. So this is basically the person who started the phenomena of dental radiology, of radiology basically. His name is Sir Wilhelm Conrad Roentgen, 1895. So basically, Sir Roentgen was the first person who discovered the dental X-rays, and what he did was he took X-ray off his hand basically, and at that time, uh, when he took the first X-ray in 1925, and then the first dental radiograph was taken in the 1896. So from that period to now, we are now in the digital era right now. So all because of him, we were familiar with the innovation of dental X-ray. So thanks to him. So in right now, in our modern era, what type of dental X-rays we are having and how much we have progressed from a plain film, or you can say that old printed form of the X-rays. Now we have a lot of new type of dental X-rays available, out of which you are familiar with, I guess, with the panoramic imaging, digital OPDs, the digital X-rays, and the new one which is right now being used for the treatment of dental implants. It is basically CBCT. So CBCT basically has a more precise and efficient thing. It is basically used in implant industry, and it basically helps in assessing the bone height, and also helps in assessing the bone figure before placing implant to reduce the risk of complication afterwards. Okay, so CBCT is something like a 3D thing in which you can analyze from all the aspects of the bone level and see how close the dental implant is towards your if you are putting in the mandibular molar, in the mandible, you can see that how much is the inferior neural nerve very close to the implant. Okay, so it has made life very much easier, typically. So we started with basically a film, and now we are towards a digital era. So how much the dental X-ray has been revolutionized. Okay, so what is basically radiology right now playing a key role in dentistry? Because basically it is playing a key role in diagnosing the hidden caries, periapical infections, cysts, and bone loss. We will discuss one by one all these things. Treatment, it is playing, as I said, it is playing very much major role in the treatment planning, especially in the field of orthodontics, endodontics as well. Very much in endodontics, when you are going for a root canal procedures, you need to check again and again with have you achieved the proper working length, have your beta bacha been cut back, and you have successfully obturated or not. And if you are like in oral pathology, you have to see like is there any radicular cyst or any kind of a tumor or any kind of radiolucency, and you can see that, and also you can also see the swelling or infection as well. In oral surgery as well, in the prosthodontics as well. Oral surgery, you need to you can also plan very much earlier how much it is difficult to expect the tooth, so you can make an idea about it. And especially when you are going for the infection, you need to have an OPD for it. And then you have, when you are also in the prosthodontic field as well, sometimes X-rays do play a very much role, because they help you in the assessment of the bone condition as well. How much the bone can, how much density of the bone is there, and will it will withstand the dental implant or not. Okay, so for example, it can if you a periapical can confirm the length in the visual root canal before the root canal, as I told. You can also track the healing after procedures like extraction of bone graft. So you might have seen the patient coming back to you after you have extracted a tooth with a little bit pain or a dry pocket. So it also helps in diagnosing such kind of things, if there is any bony tissue left, or when you are have done the extraction, or is there any kind of abnormality. Okay, so it helps a lot. Okay, so what is basically the physics behind these X-rays? Basically, X-rays are electromagnetic radiations. They are invisible. They travel in a straight line, and they penetrate the matter. Okay, so this is a picture in front of you of an X-ray tube, and it contains a cathode, a node, and a target. Cathode is basically your negative sign, if you can see this in the blue color, and a node is basically the positive sign in the red color. Okay, so whenever X-ray basically travels from cathode to a node, okay, when X-ray emits, basically it penetrates the matter. You are targeting the film on which you have been placed, and that when it penetrates, it produces a emission effect. So when the X-ray rays, they travel, they are absorbed basically in the structure that near you have placed the film. Then it produces a photoelectric effect there. The X-ray waves scatter around that component, around that you can say that around bony tissue or soft tissue, and it produces a compound effect. So in compound effect, basically all the X-ray rays that have been emitted from your X-ray beam, they are scattering. Okay, and when they scatter, they produce an image on the film that you have placed. Okay, so what factors do affect these image quality? The density affects it, contrast, sharpness. Basically, density in such a sense, you can say that when if your bone is a little bit fragile, or it will appear as a much more in the radiolucent. Okay, it will appear a black, and when it will be a more dense, then it will appear as more whitish. Okay, so there are we basically broadly classified the dental radiographs in two main categories. Okay, intraoral and extraoral. So first we will discuss about intraoral. Intraoral radiographs include periapical, the one you are more familiar with, and you also do in your normal day-to-day life when you are going for the root canal, when you are going towards extraction. We mostly do it periapical. So it is also known as PE X-ray. Okay. Then you have a biochemic X-ray, which is basically you can see here, and it is basically a taken when you are going towards multiple restorations. Okay, and when you have to check both the bony conditions of upper and lower teeth at the same time. So it has one advantage. In periapical, you can just assess only one quadrant or two or three teeth at one time, but in biting you can see the upper and lower quadrant teeth as well. Okay, then there is occlusal. So basically, as the term occlusal means, at the one time you can be seeing only one occlusal view, either of upper teeth, your maxillary teeth, or lower teeth, mandibular teeth. Okay, this is the picture of lower mandibular teeth. Then we are having extraoral radiographs. You all are familiar with the panoramic X-rays, which are also called as OPG, orthopantomogram. Okay. So in extraoral, mostly we go towards OPG, and then when you are in the orthodontic or when you need to do a orthodontic case, treatment planning and others, then you go towards the phallometric X-ray, which is also known as lateral theft as well. Okay. Then PBCT, this is a new type of arising X-ray. Basically, it is a cone beam community topography. As I told, when you are placing implant, and if you want to assess the bone symmetry and bone height as well, and you need to see that where is the inferior alveolar canal, where is the blood vessels, okay? So it gives you a 3D view basically. Okay, so it's much better than the previous one X-rays because it gives you a precise and excellent view. Okay, so what are the indications for dental radiographs? Why are we using dental radiographs? Dental radiographs are basically used in these 5 places, more or less. When you need to detect a caries, as you can see in the picture, this is a molar, this is the first molar, the 6th one, and there is a caries in it, and it is expecting the pulp on distal pulp on. Okay, so in this case, when you get an X-ray, a patient will present to you with the pain in molar, and he will be saying the pain is not going away. So then you assess that it is a irreversible Pitus case. For the confirmation of this your diagnosis, you have to go towards X-ray. And in this X-ray, it confirms that this patient is a case of irreversible Pitus, and it needs basically root canal option. Okay. So for the confirmation, you are going towards this thing. Okay. Then you have a periodontal disease. Periodontal disease assessment. How do you do a periodontal disease assessment? Basically, in periodontal disease assessment, you see the interdental bone. How much the interdental bone has been eroded, or there is a bone loss there. In this radiograph, you can see there is a both vertical as well as horizontal bone loss, and you can see these basically these are the black triangles. You can see a bigger black triangle that is suggesting that there is a lot of bone loss. I think this is a case of grade 3 or grade 4 mobility case as well, because you can see there is a very much bone loss in the premolar of this patient. Okay. Is my voice clear, guys? Please do let me know in the chat kindly. Hello. Am I audible? Okay. Thank you. Then you go towards the endodontic evaluation. So in endodontic evaluation, you need to assess as either the root canal is done properly or not. Either you have obturated properly, have met the working length or not. Okay. So this you have to assess basically. Okay. In this picture, you can see that this is the maxillary molar and it's obturated. It has 3 roots, and this is also going in sinus, but it is basically well obturated. Okay. Then we use to detect the pathologies like cysts and tumors. Okay. You can see in this picture there is a very much big radiolucency. Okay, so the structures that will appear black, they will be called radiolucent, and the structure which will appear white in the dental X-ray, that will be called radiopaque. So you are seeing radiopaque crowns in this picture, and the root canal of one lateral incisor. You can see that there is a root canal done in white color, and the both centrals have a central hollow. You can see it is a hollow circular radiolucency, which is basically a. Can you guys detect what is this thing? Is my side not changing? Hello, is my side changing? Which slide are you seeing, guys? Okay, let me check. So, just a minute. Just a minute, guys. Give me a minute. Now let me know. Is it visible? Can you see the picture of lateral cap? Hello. Kindly type in the chat box, please. Can you see the picture? I hope you guys can see the picture. Okay, thank you. Basically, it is involved in detecting the orthodontic treatment, and for the treatment planning as well. Now, this is a very important concept, principle of radiation protection. Uh, it should be taught, and it is also taught, to be honest, and it should be on your tips as well. What is basically a LARA principle? You might have read about it. LARA principle is basically as low as reasonably achievable. Okay, so you need to keep the radiation as much as you can kept as low. For that purpose, you need to wear a lead apron and thyroid collar. Why I have mentioned lead apron here and thyroid collar? Because these two basically prevent harmful rays of X-rays to your body organs. And in the situation, especially when there is a pregnant woman and a person who is immune system immunocompromised, you need to make sure that they do wear both of these when they are going towards the X-ray, because X-rays are very harmful for the pregnant woman. Okay, so do make sure, and I know that most of the people don't incorporate these two things in their normal practice, but you should do an X-ray with these two things. You should wear yourself as well, and you should replace these on your patient as well. Okay, so there is a proper collimation of filtration process. You can there is a dosimeter. There is a specific dose like 5 gram So that needs to be kept in order to be safe from the radiations of harmful radiation of X-ray. So what you can do is you can have a operator protection shield, distance shielding as well, and as I have placed a sign, you can place the signs of radioactive harmful, and you need to keep the dental exposure as less as possible, okay, to avoid the harmful rays of X-ray. So in this picture, you can a little bit analyze more. LARA stands for as low as reasonably achievable. It is a radiation cavity principle used in dentistry and all radiology to minimize patient and operator exposure to the ionizing radiation while still achieving the necessary diagnostic results. Okay, so you have to prevent yourself and your patient from both the harmful ionizing radiation. Okay, you can see in both there is a discrimination. There is a difference between film X-rays that are used old. Right now, we also use film X-rays as well in some clinics. But now there is a modern era and we are using digital X-rays. Digital X-rays basically have an advantage of having less radiation as compared to the old ones, the film-based. They have more radiation and their results are very much great. However, these results are very much good and they give you results in seconds. In old time, like you have to prepare the film, then you have to watch it under the solution, then the results come, and then you can see the both your radio X-ray. However, now you just need to just make a click and the picture of X-ray in front of your laptop, in your digital phones and cameras, etc. Okay. So this is basically a digital versus conventional radiography. Digital one is sensor based. Basically, there is a sensor is being placed in the mouth and just you need to click it and X-ray is appeared on your screen. Okay. However, the old one was conventional one was the film based, which was very much hard to take a X-ray. You need to place the radio beam towards the patient mouth in such an angle so that you can get a X-ray. Okay. So advantages of digital are basically it has a much good speed. You can store it in your digital formation and you can manipulate as well. Like you can make a display case of it and you can also teach your patients as well. And the digital one has basically a good image quality and resolution as compared to your film-based one. So what do you interpret basically in your dental X-ray? There are you look first towards the radio opacity and radiolucent. All those structures which appear radiolucent will be black in color. Okay, it should be your pulp. Okay, mostly it is your soft tissues. Okay, however, and the ones which have swelling as well, they will also appear in radiolucent. However, the ones which are like bony structures, they will appear as and have more density, they will appear radiopaque, whitish in color. And the above picture, you can see there is a crown filling, which is appearing radiopaque, and then there is a implant, not implant. There are two canals which are being root canals. Okay, these are obturated. Basically, gutta percha is being changed. Gutta percha will be seen as radiopaque. Okay, and then there is a pin. Okay, pin post place will be also radiopaque. Then you need to see the normal anatomical landmarks when you are viewing the X-ray. Okay, then you can assess however is there any problem in this dental tissue or not. Either there is a pulse problem, there is a bony problem. Okay, you can see the common pathology, caries, abscess, cyst, and bone loss. So this is a very important thing that I want you to guys know about it. What are the common errors we do in radiography when taking radiography? The common errors which we have encountered during radiography are cone cut, overlapping, foreshortening, elongation, or motion architect. So in these two pictures, I hope you guys are not very much familiar, but I will let you know that in these two pictures, the common error that is being present is a cone cut. And now what is a cone cut? Basically, a cone cut happens when the X-ray beam does not fully cover the image receptor like like the sensor or film. So the part of the image is missing or blank. In simple terminology, in simple words, basically what happens when you place your X-ray beam out of the mouth of the patient in such an angle, and you want like to take a X-ray of your both last teeth, including wisdom or last two molars of molar. But what happens is when there is a shift in any angle or there is any interruption between the film and cone beam, it could be your finger as well. Most of the time it is basically finger. You have placed the finger on that side when you have spotted that molar. So what happens is basically the radiations come from the cone beam, and if they don't reflect back, and what happens, and there is a whitish, you can see whitish gap seen on the image, as you can see in here. Okay. So example is, as it's saying, is you take a periapical X-ray of a molar, but a white rounded area appears on the image. There nothing shows that a part of the sensor was not hit by the X-ray beam. So basically, the rays don't hit there. Okay. In the lower picture, you can see a better thing. There the film is placed, the angulation is correct, and you can have a proper picture. Okay. When you have misaligned the correction of your angulation of X-ray, there is a part of the film that has not been exposed, and it appears as a pointer. Okay. Then there is the overlapping. What is overlapping? Basically, overlapping occurs when each appears to be on the top of each other in the image, usually because the X-ray beam was angled incorrectly. So this is a very good phenomenon. Basically, you can see both of the above and lower picture. What you will be seeing is that in upper picture, all the teeth are in one alignment. But in the lower picture, teeth are in alignment, but they look like that they are very much close to each other. Like one teeth is over the other teeth. Okay. So this is basically overlapping. Okay? You take a bite in X-ray to check for a cavity between the teeth, but the teeth look like they are fused together. The best terminology there is they are looking like they are very much fused together, but they are not fused. There is basically a interdental bone present, but it appears like there is no interdental bone between them. Okay? And this can basically hide the cavities and make diagnosis very difficult. So this is basically overlapping. I hope you guys got the point. Okay, then there is foreshortening and elongation. So basically, these are the two shape distortions. What happens in foreshortening is the tooth looks like too short. As the terminology foreshortening, tooth will appear very much short. Okay, but in elongation, the tooth looks like very too long. Now, why do they appear like these things? Because you have placed your cone beam so much in front and in a very wrong angulation that you wanted to have take a X-ray of root and crown, but your angulation was very much you can say misaligned, that it took the picture in an elongated view and in foreshortening view. For example, if the X-ray beam is angled too steeply downwards, and a central incisor may look short and stubby for shortening. Okay, and if the angle is too shallow, the same tooth may look like longer than its elongation. I hope the picture and in front of the diagram you can see that that these cones they raise when placed and the film is there, and just because the change of an angle, both you can see elongation or shortening. Okay, this happens very commonly, I guess, with you guys as well. Motion artifacts. What are motion artifacts? Basically, these happen when the patient or the X-ray machine moves during exposure, causing the image to blur. You might have noticed sometimes you do a good X-ray, your whole angle and your positioning is very accurate. But what happens when the film is generated? It is basically blurred or vertical in color. What basically happens is there is a little bit, you can say, motion or movement of the on the operator side, or it may be on the side of the patient as well. For example, you are taking a panoramic X-ray, you are taking basically OPG X-ray, but the child moves their head slightly. When you are taking OPG, you guide your patient that he keep the head in the front, okay. But what happens in sometimes patients don't follow the instruction and they move their head, and then these kind of picture appears because there's a whitish or blur, you can say. Okay, these are blurry and unclear, making it hard to interpret. Okay, and in such a picture you can't interpret basically any kind of the thing. Just you are seeing blurriness and all the things are blur. Okay, so when doing radiography, you need to follow the inspection control as well. This is a very important part of your practicing radiography. Okay, uh, so all the time when you are doing a radiography, because your mouth is being placed in the for the periapical exercise, if you are doing a conventional method, or in the new as well, when you are placing a sensor, make sure the sensor is being handled with all the protocols. There is a proper sensor barrier over it. Okay, and you have to replace that sensor barrier all the time. Okay, and you need to disinfect your sensor a little bit, not very much that it sparks. Okay, and you have to make sure that you follow all the infection controls when doing radiography. You have to wear PPE yourself, and also you have to make sure that your patient also wear a thyroid collar or and also the lead apron as well, so that he has not gotten all the harmful effects of it. So basically, what are the legal and ethical considerations regarding it? Uh, Legal and ethical considerations regarding the radiography are that you need to take the consent first from the patient. Whenever you are like taking an X-ray, you have to ask that I will be taking film in your mouth. Can I do it? This is for the purpose of a diagnostic procedure. Like you have to explain it about it. Take it. Similar for your center as well. When you are taking a digital radiograph, okay, uh, you need to explain it. And then for the OPG as well and GDCD, you have to explain the instructions as well. Okay. Then you need to keep their record storage. Make sure that at least you have a file copied or a picture taken in place in your data file base as well for the record purpose as well. Most of the time in Pakistan, people do lose their OPGs and X-rays as well. But now it's the time of digital era. Thanks to the technology, we can easily save these X-rays on our computers if you are doing digital following digital radiology. Otherwise, it's better to take a picture of radiograph and keep in your clinical or hospital data record as well. It will make your life easier. You don't want again and again to take an X-ray of a patient and you don't want to expose him towards harmful waste if there is no needed. Okay. Then again, this as I said, you have to follow the radiation safety laws in all the terms. If and only if you see that that the patient needs a dental X-ray, go for it. If you say that if on the clinical inspection you find out that this thing needs to be can be that dental X-ray can be modified, like in the cases of the fillings, etc., or a little bit a crown cutting or something like this. So there is no need for these such kind of cases to take an X-ray. Just when there is a cases of irreversible pulpitis, patient is very pain, when you need to take an when you need to do orthodontic planning, then you need to take an OPG, and when you are going for implant, then there is a very much important thing. Okay, you need to take them. Then radiography reporting responsibility, it is your responsibility to make sure that radiograph is being taken correctly. Okay, practical guidelines for dentists. Basically, a dentist should know how to write a radiographic prescription in that area. Uh, I will. I hope you guys are familiar with radiographic prescription in that area. Most of the time, what we do is to save our time, we do write a radiograph of upper fourth quadrant to be done or this to be done. The best method is to draw the both quadrants, all the quadrants, four quadrants, and mention the first number as well in any numbering system as well, apart from this as well, so that to make sure that the radiographer and your operator takes the right to the radiograph and you don't need to repeat the X-ray. Okay, so you should know how to write a radiographic prescription criteria basically, and when to write a radiographic criteria. I have told you not to be right in all the cases. That I am stressing a case of a little bit to carry this filling this document, and then I'm going for the X-ray. When in that term, basically patient is not having a pain, then why are you prescribing a radiograph? Okay, you can see the clinically that it just needs to be refilled. Just go towards the clinical procedure of filling respiration. In such cases, there is no need for a radiograph to be done. Okay. Technique selection, basically this is very important thing, and our the next session will be mostly about it, and you will discuss it will be discussed in very much detail. Okay, all the techniques, however, and how to take X-ray, how on which angulation you should take an X-ray of periapical, what is basically paralleling technique, what is bisecting technique. So it will be very much discussed in detail. Okay, and then you need to make sure of all the quality protocols when you are doing radiography. As I told, you need to follow ALARA in all the terminology. Okay, so this was all about my today's lecture, and I hope you guys got the point of dental radiology fundamentals and principles of practice. If you guys have any questions, do let me know in the chat box, and I would like to address them. Also give me the feedback as well. Did you like the session or not? So basically, there is a one question I can see in the that why test area is not covered during radiography. Okay, so basically, test areas do not covered during radiography because your main concern is with your dental tissue, okay? And the test area has very less radiosensitive organs, okay, compared to the all the other organs of the part, okay? That's why it is not covered. I hope this query is being answered. And what are the next questions? सर प्रेग्नेंट वुमन में हम एक्सरे करवा सकते हैं? To be honest, to be on the safe side, I would highly recommend don't do it. You can do it in the second trimester, basically, but best thing is if you are going towards it, then you have to make sure of that the patient is pregnant woman is wearing lead apron and both the thyroid collar as well, because basically the dental X-rays rays are basically catatonic, basically it affects the fetus. Okay, so you need to avoid as much as you can. But the digital X-rays are like they are relatively less harmful, so you can always go towards them, but try as much as you can to avoid them. If there is a very much need, then you can go towards it. If there is okay, if periapical or apex locator good for working and periapical or apex locator, basically they both are the same thing. Okay, apex locator is a very good thing for working men. If you can afford it, that's a very good thing. But if you don't have it, you still can do the root canal, and you still can have a full working length if you have that much dexterity and you have a very much good hand in root canal. Okay, but yes, they are a very much golden option if you have it. Okay, in your clinical practice. In which condition we will use bisecting technique? Okay, Dr. Shakti, this topic will be very much discussed in the next session, and keep this question safe for that, and hopefully your all queries will be answered for the next session, because all the this is about section is all about the paralleling and bisecting techniques and where they are used and where they are not used. Okay, so I can answer, but the thing is all the curiosity will be ending right now. Is anyone else having any question regarding it? I hope today's session was a little bit fruitful to you guys, and it was productive as well, and you learned some new things as well. I tried to make as much as uh, like we can say the concept gulpable and absorbable for you guys. Okay, so there is no any question. If there is no any question, let me know. Then we can conclude the session. Thank you for attending the session. Highly appreciate you guys being here and listening to this session. See you in the next session. Inshallah, it will be on 20th June. ख्याल रखिएगा अपना, तब तक के लिए अल्लाह हाफिज़.